A very good afternoon to one and all. Thank you for this opportunity. So today we'll discuss about the case presentations on osteoporotic fractures of the spine. So without wasting time, moving ahead with this. This was case number one. This he was an elderly gentleman. Age was around 74 years. He just had a small slip and fall at home, following which he got an L1 fracture, which is very well visible to all of us here. This is a pre-op X-ray. This is a pre-op MRI in which we see the collapse of the vertebra, the wedge fracture, which has happened with slight retropulsion, minimal amount, and the stir hyperintensity indicating the acute trauma of the vertebra, which was leading to pain and everything. All the instability signs he was hardly able to get up. And so we decided to do balloon kyphoplasty for this particular patient. There were absolutely no neurological deficits in this patient. So this is how we actually do it. So we use these percutaneous Jamshedi needles. We put the balloon catheters. We inflate them under Siam guidance. This is how it appears. And following which we did the cementing. So this is a post-op X-ray, the AP and the lateral views of L1 vertebra. If we compare it from the pre-op and the post-op X-rays, we see that the vertebral height is well restored. A bone which was collapsed has regained its height. Thereby, the patient obviously felt really well. He was able to walk the same day and go home the same day. So that's the beauty of this procedure called balloon kyphoplasty, which really, makes the pain really get better, like a magic almost. There are no sutures used here. It's just a small stab incision which is used to do this particular procedure and really works out wonderfully for elderly patients. So let's come on to another case. So she was an elderly lady, age was 67 years old. She had suffered this T11 and L2 fracture. So at the level of T11, there was a cord compression as well, and the vertebra was almost gone. So what we did was we did a decompression and fusion for this patient. We used cemented screws, rather we should say cement augmented screws, because the DEXA score was very low for this patient. It was -4. So in view of osteoporosis, to prevent our screw back out cases and all, we did this. And for the lower fracture, that this L2, which we can see here, we just did a balloon kyphoplasty. So for the above, where we needed to do a correction as compared to this, where we see the spine is bent, so we made the spine straighter using these cement augmented screws. And for the lower fracture, which was quite small, without any compression over the nerves, we just did a balloon kyphoplasty, leading to really good outcomes for this patient, and she was really able to walk just the next morning following the procedure. So it becomes quite satisfying for the patient. A patient who is bed bound for quite some time, she feels quite happy when the pain is relieved and is able to walk. This was about it. So again, coming to another case, she was a lady of around 50 years of age. She had suffered these multiple fractures because of a fall. And yeah, so we did this a decompression and fixation surgery for her. And this is her. Following the surgery, she was again able to walk without any serious pain or something. She was bedbound for like at least some 3 weeks preoperatively, and this was immediately the next day, day one of the surgery, when she was able to walk and went home the next day. So let's come on to the case four. So we have this 43-year-old lady with us who had suffered a fracture. She had weakness over the legs as well, inability to stand or walk. It was a T5 burst fracture, as we can make out from here. The T5 is almost gone. It has become like a vertebra planar. There's compression over this cord. There was myelopathy as well. To some extent, there was slight numbness over the legs as well. So we did this. We did 2 levels up and 2 levels down. We did decompression and a fixation surgery for her, following which the things got sorted, and over a couple of months, she was able to regain her mobility. So, and this is another patient with us, case number five, where this lady suffered an road traffic accident and she suffered the C6, C7 fracture dislocation. This is the MRI, the sagittal cuts, the axial cuts, and this is the CT scan of this patient. We can very well make out the fracture dislocation, which is visible to us here. Following which, we did this decompression and fixation surgery. This is the post-op MRI of this patient, and this patient is also making a good recovery now. Coming to case number six. So moving from open surgeries to minimally invasive at this current point of time. So This is what we actually did. So this elderly gentleman again had a fracture with cord compression with numbness over the legs. So we did not really open up and do anything. This is me only. This is our own OT setup, our own team. And this is how and what we did for the patient. We used percutaneous wires, percutaneous screw fixation. This is the CM image of the same patient. This is the final post-op X-ray. So just conveying a message that such fractures can be very well sorted out by minimally invasive spine surgical methods without really opening up the spine, causing blood loss, causing pain, long rehabs, and nothing of that sort. So minimally invasive surgery is a beautiful surgery which really helps in reducing the morbidity of the patient and gives beautiful results, obviously. Now we have come to endoscopic spine surgery as well. You people might have heard about this. So now the fixation is done by the screws percutaneously without opening up, and then we use this endoscopic thing to decompress the compression which is happening because of some bony compression or some disc which might be then impinging upon a nerve. So this endoscopic spine surgery can be used in cases of trauma as well. So thank you very much. That was about the case presentation for today.